I'm just going to give you a real quick overview about what I do in SunCloud, and then we'll kind of get into things here. If you guys have any questions, feel free to put them in the chat, and we will make sure that we have time to get to them. So I am a child and adolescent psychiatrist. I did my medical school and undergrad training in Madison, Wisconsin, and then did my adult psychiatry residency at the University of Illinois in Chicago, and stayed on there to complete my child and adolescent fellowship training. After that, I worked at Hartgrove and did some inpatients, predominantly child and adolescent psychiatry. And then also, more recently, I've been down in Southern Illinois doing outpatient child and adolescent psychiatric work. So I have been at SunCloud now for about 7 months as we've opened up our adolescent psychiatry line. SunCloud is a PHP, IOP, and residential level of care focused mental health treatment center, really designed to take care of patients who have co-occurring disorders, so multiple psychiatric disorders, usually related into the eating disorder range, substance use disorder range, or trauma range, and then kind of the anxiety and mood disorders that follow with those. We are led by Dr. Kim Dennis, who's certainly a national leader in the eating disorder and co-occurring disorder space. Previous medical director at Timberland Knowles, and so I was very grateful for her to be able to bring me on to expand into the adolescent realm of things here over the past 7 months. So we are located in Northbrook for child and adolescent, or adolescent and adult services. Our residential is a couple-minute drive from our PHP IOP location. Our services are on 2 different stories of the same building. So we're in Northbrook for the adolescent and adult services. And then we also have adult and adolescent services in Naperville, and then adult services in Chicago, the Lincoln Park area there. So that's a little bit about SunCloud and a little bit about me.
Well, and Dr. Alex, one quick question. And
sure.
I don't know if this is going to be interesting to everyone else on here, but I've sent 3 referrals to SunCloud, and Dr. Alex does the intakes. So I was floored by that, because I don't know that I've ever had a psychiatrist spend hours with a patient and do the intake for a program. And so I do, and not only, and a couple of times you made the referral that somewhere else would be a better fit. And I thought that was amazing, because a lot of times when you send patients places, they just take them, but you were very thoughtful in diagnosing them and meeting with them and kind of getting them to the right place. And so can you talk a little bit about that? Because I've never seen that before.
Yeah, so it's certainly in medicine and in healthcare in general, I think if you're used to being a hammer, everything starts to look like a nail, and that is definitely not what we do at SunCloud. There are clearly treatment locations that have specific strengths, and there are places that are definitely going to be designed to take on certain patient populations more than others. It's really important for us that we're doing the best thing for the patients in the community, rather than just trying to fit somebody into a mold that they don't fit into. So we're really looking to make sure that we get that right match kind of out the gate, and that's part of the reason why our intake assessments are so thorough. There's a lot of collateral gathered, a lot of time done for these assessments. Actually, sometimes I get pushback from families about how long the assessments are, although I can say virtually 100% of them by the end are very thankful for having gone through the process. So yeah, it's a little bit different than what you'd see at other locations. This is really designed to try to make sure that we're finding the right people and getting them the help. And of course, we know everybody else in the space, despite being the 3rd biggest city in the country. There's a very finite number of PHP IOP programs, residential programs in Chicago, and between all the staff and the probably centuries of experience they have combined here, everybody knows everybody, and we're certainly looking to get people into the therapy that's most likely to help them on the path to recovery.
Are you seeing any themes coming in just following the pandemic? Are you seeing any certain diagnoses, or are you seeing any particular impact that you feel like social distancing and the pandemic has had on our children and adolescents?
Yeah, so I just gave grand rounds on this. So there's a bit of what I've seen, and then also a bit on what the national and international data have shown. Off the bat, the number one disorder that has had an increase from the pandemic has been in the eating disorder range. I don't know that that's necessarily terribly surprising, but what you probably heard about in the news and what everybody kind of experienced was an increase in weight for a lot of people when COVID started. That has been also the case in the adolescent and child population. Actually, even for younger kids is even worse, because I'm sure many of you either have or remember or have been around younger kids. They are very physically active, and by restricting that, that's a huge source of their calories being expended. It's less so as we get older. It's more controlled through our diet than physical exercise when we're kids. But there's been a substantive increase in people's weight all across the country, and that is one of the bigger predictors for going on to develop eating disorders. So the data coming out of individual centers is showing like around 100%, in some cases over that increase in eating disorder rates. It's honestly, I think, the biggest single year-over-year change in the prevalence of what was previously a relatively stable disorder that I may ever see in my entire lifetime. And this is kind of a wild time with COVID, as we all know, and its changes have been pretty dramatic. So that's definitely one of the big ranges. Everybody's had a lot of concerns about social anxiety, and I certainly am seeing a fair amount of that. Things related to school refusal and school avoidance are going to be much harder when we've had this time where it said, hey, no, stay at home, sleep in until 2 minutes before class starts, maybe participate, maybe don't, and do whatever else you're going to do. It's obviously been a wild time to be an adolescent, and so lots of issues there. Certainly, for many kids, as is the case for many adults, their family life may not be the greatest. And when you're stuck in, close proximity with people who you don't have the greatest relationship with, who may or may not be actually abusive, this is certainly a recipe for things not going well. And so we've seen that in the adult space, and I'm definitely seeing that in the adolescent space as well. That if home life is tough, being cooped up in home life makes it extra tough. So those are probably the biggest areas that I've seen change with COVID.
If you all have any questions on here, I didn't mention this, feel free to put them in the chat if you'd like the doctor to answer any questions you have. I know we're going to go through a lot of different things, but feel free this is an opportunity. If you have any certain things that you want to know about or learn, feel free just to put the question in the chat and we can go over it. And I think Dr. Alex said something that's interesting, because we've seen that too, that a lot of parents are saying, and at least I'm finding this, a lot of parents are saying, after the pandemic, we're having a hard time like reestablishing boundaries and setting limits. We're seeing a lot of like video game addiction. A lot of parents are saying that their kids are really like isolating in the room and spending more and more time on video games. And we know, like you've discussed, kids with anxiety and ADHD can be more even prone to addiction. What advice would you have to kind of guide those parents?
Yeah, so the world has certainly become increasingly digital and was already heading that way, and then kind of took off like gangbusters with the pandemic. I think important to understand that the modern technology and modern design of a lot of things is intentionally designed to be addictive, is intentionally designed to keep your attention, keep you away from doing other things, right? TikTok and Facebook don't make their money based on you logging on for 1 minute, talking to somebody and then leaving. They make their money from you staying on, scrolling through ads, and having high user engagement, right? So there's a lot to be said about what that does. Mental health was not in a good place for adolescents even pre-COVID. We'd seen kind of the highest year-over-year increases in suicidal ideation and suicide attempts heading into the pandemic. And I certainly suspect when the data comes out that it's going to be even worse post-pandemic. And I think a fair amount of that is probably driven by the electronic access and what kids are doing with that. I will say there's definitely some nuance to be had here. So there is a difference, certainly, from kids who are scrolling pictures of influencers and models all day. It's probably some of the most destructive things that you can be doing for your brain, as opposed to a kid who's on a Discord server and talking about the latest anime or K-pop or whatever more niche interests they have that they're very excited about to share in a community with like-minded individuals. Not to say that the latter can't also go off the rails, but it does depend on what's going on. I think, generally my advice to parents is that having good boundaries around electronic use is critical and is part of your job. A lot of people may feel differently, but I think really when you take a look at it, this is an important part of what you're doing. If you were previously letting your 16-year-old, go into, a place where a whole bunch of people were going to be staring at them and commenting on them and talking about how their body looks, you might be aghast, right? If you were sending your 16-year-old to that now, but your 16-year-old posting pictures, on the beach to Instagram and trying to get as many likes as possible, or as many fire emojis as possible is very analogous problem, and in some ways even worse. So having, good monitoring and discussion over, appropriate use, safe use, and then actually monitoring that and having boundaries about it is really important. I think a lot of people aren't comfortable sometimes saying, you're still a teenager. We know your brains are kind of designed to take on some of these things in a way that they're getting a bit hijacked by the programs intentionally. And we know your ability to kind of judge risk and how these things are going to affect you long term is not the greatest. And so teenagers get into problems in a hurry, on the internet. And I think a lot of times it would be great if somebody was overlooking that. And it just doesn't end up happening.
Well, and I think the reality is I had a child in my office this week who was 2. I was seeing the sibling, not the 2-year-old, but the 2-year-old had the iPad and was playing a video game and was like navigating and scrolling. And, we didn't really, honestly, back in the day, I would have thought something of it. We were like, oh, that's normal. But the other thing, and I don't know how many of you on here work in schools, but I've run into this a lot recently, probably over the last 4 years, where parents will tell me when they try to set limits, one of the things that comes up is their kids will either become emotionally aggressive, physically aggressive, or threaten self-harm. In particular, if they say like, okay, you know what, you need to go to school, we're taking your electronics away, kids will get really, really agitated. And a lot of times that gets really ramped up. Sometimes parents are even faced with having to call 911 and things like that because it gets so intense. I don't know. I know we're going to talk a little bit about how to assess for that, for kind of at-risk behaviors. Do you have any thoughts on that? Because I know we take that very seriously, but for some kids that does become what they say in response.
Well, I'll tell you a couple of things. First of all, no kid gets there overnight. So there's no 13-year-old who has had great limit setting and has been in this situation where they've always had to earn or have limits around things that all of a sudden just gets into a huge meltdown and starts stabbing people or cutting themselves. That's not how these things come about. Families may tell you that, but they're lying. So I don't know how else to describe that. So the question is, once you get to that point that you've got that problem, what do you do? And that's a great question. But that is not just something that's spontaneously coming about. Right? The teenagers' brains are kind of modeled and evolving over time in response to kind of what their environment's showing them. And so what usually happens is that you've got a kid where they push boundaries a little bit. They want like that a bit of time. They want that extra thing. You say, well, it's going to avoid something. There's not going to be conflict if I do this, so we'll say yes this time, right? And then they get away with that. And then next time it's a little bit more. And then, hey, maybe they're getting bullied at school. Maybe they're not doing so well in school. Maybe they just got ghosted by a romantic interest, dropped by their friends. And now there's all this more impetus to get away from the world. We pushed on these boundaries in the past. We're going to push harder, right? And so if you're at the point where you're getting those kind of responses, I think, it tells you a couple of things. One is that there's probably some more issues going on with that kid inside their head. It's not like that's just a spontaneous response that should be normalized or expected. It's not what the average kids out there is doing, is saying, if I don't get my electronic, I'm cutting myself. The second is trying to figure out kind of what may have gotten there in the environment at home and what you can do to change some of those things. They're not going to change overnight, right? You can get there overnight, which is why I made that a point to begin with. You're not going to get out of that overnight. And so you're going to have to figure out, a new strategy and a new discussion over kind of how this is going to go and what the limits are going to be. But what you absolutely can't do is positively reinforce those types of behaviors. Right? Our brains are exquisitely responsive to positive reinforcement. If paychecks stopped going out to everybody here, I have a strong suspicion that about 90% of you would not be going into work a month from now, right? Our brains are designed to work around positive reinforcement. And so almost assuredly, when you look at these cases, we have positively reinforced this use, whether it's to allow somebody technically called negative reinforcement, but still a type of positively reinforcing behaviors where getting on this game lets me not worry about the anxiety I have. Getting on this game lets me forget about the frustrations and sadness that I have. Getting on this game gives me, this reward of being able to play with other people that I enjoy, getting this dopamine hit from something, being on the social media every time I get that like and that emoji, it gives me that reinforcement. And so figuring out what we're going to do to create positive reinforcement in non-electronic ways and have good pro-social interactions with other people in non-electronic ways is part of that. And then also, again, just making sure that they're an understanding that it's not your right to be on Instagram. It's not your right to be doing these things. I guarantee you I've read the Bill of Rights when I was in high school, and I know it was not on there anywhere. So making sure that kids just have an understanding of kind of, if we're going to be doing these things, there needs to be some guidelines and some parameters to it.
And one thing I try to tell parents, and honestly, sometimes I have success with it and sometimes I don't, because I think this is probably one of my biggest challenges with the population I work with, is that the parents have such a hard time and the kids get so aggressive when they try. We talk about don't do it just out of the blue, don't just whip them away, but try to kind of have a conversation.
Yep.
But I know you all have seen there's some kids not even leaving the room, and the other, I think, dilemma that we're up against, and we're going to talk reality here today, because that's kind of what we do. There's not, Dr. Alex and I were talking this morning that we have a couple kids that are waiting for about a month to get in somewhere. And so now we have these situations. And so any suggestions on ways, we can support students and families, because I think we are facing kind of a crisis here where places are filling up and a lot of these kids are struggling. And like you said, that, parents, some of the parents I work with, they can set those limits, but there's some that they really, really struggle. And they have their own addictions too. And so it gets really complex.
Yeah, it does. The world is not easy, and I don't know that it's getting any easier. I think it's probably going the other direction. And so obviously there's kind of the best case scenario and, the best practice solutions, and then meeting the reality of the world and where people are at. Again, I think really one of those focuses, it can feel like you're slipping away from your family and from your kid. And it's obviously a concern and a problem. And so figuring out anything you can do to be doing things together that they're interested in, that are in the material world and not online, is great. If you can't do that, and another semi-analogous thing is get into their world and do those things with them, so that you're around with them, able to set limits and boundaries around it. There's nothing wrong with hopping onto Minecraft with your kid and spending some time with them that way. Again, it's got to be in a reasonable manner, not for 20 hours a week, but definitely something to be said about meeting people where they're at, and an important thing to do. And so that's that kind of delicate balance that parents have always done. It just got much, much more difficult to be a parent. You need to understand, the technology. You need to be able to, have their screen mirrored, or have a, way that you're accessing what they're doing. In some cases, you have to be able to just figure out, appropriate levels of turning off Wi-Fi and parental controls. So those things aren't easy, and kids are smart and they get around them. So you just spending time and being involved with them will be the secret sauce and the most important thing to kind of getting that. In addition, of course, to getting the professional help. But like you said, that doesn't always happen overnight. So we'd love it to, but of course it doesn't always.
I like how you said that, because I think for some kids that might even deter them from wanting to play video games if their parents are sitting next to them wanting to play. Mm-hmm. What are you all seeing in terms of, are there certain patterns you all are noticing with kiddos and families? Are you all noticing certain trends? I know some of you are in schools, some of you are in private practices. We can just speak from what we're seeing, but it would be interesting to hear what you all are seeing. What do you, are there any things or strategies that you feel like schools or private practices or other agencies could be doing to better support kids and families during this time?
So those are obviously two pretty different organizational structures. From a school perspective, I think one of the things that's happened is that so many, there's been so much chaos with everything that's gone on with COVID. Like, I had a patient just yesterday tell me I didn't even get my assignment sent to me. CPS couldn't, figure out whether or not they were even going to be present, and are dealing with all the, CPS issues that I'm far from authority on. But, I've vaguely read some news articles about, so this is, one of the big things. I know teachers have just been getting, really destroyed by the intensity of pandemic, the increased demands on them, the lack of support for, hybrid virtual and in-person learning, and having to do this kind of all on their own or with relatively limited support and limited budget. So one of the things is obviously taking care of yourself as best you can if you are an educator at a school. This has been a super, super tough time for the teenagers, but an absolutely difficult time for all the educators too. The second thing I think for educators and people in the school system is just making sure that we don't let kids fall through the cracks. In the past, I think if you see a kid who's doing really well and then their grades plummet, somebody says something, right? People are in the education space because they care, and certainly it's not for the money, right? So the people that are doing this kind of stuff, they want their kids to do well and they want their students to succeed. And when they're seeing issues that really strike them out of the blue, they have intuition, they've been doing this stuff for a while, they know what's going on. But I think what's happened with COVID is just there's so much more noise, to that signal that all of a sudden, kids are missing time for all these different reasons. And how do you keep up with, everybody who's out a week here because of this exposure and out a week there because they tested positive, out a week here because their mom tested positive, and the grades are dropping there. And is it because it's COVID? Is it because it's something else? It's a very dicey situation. So just making sure that when kids are tanking and are not doing well or are missing time, that anything we can do to have people reaching out to them, making sure that they're getting the work, that somebody's just talking to them and figuring out what's going on. If you have a kid who's like, oh my gosh, I can barely open my eyes, I'm super sick from COVID or whatever, that's obviously a very different story than somebody who's just saying, I'm not doing the work. You're like, well, why aren't you doing the work? Maybe because I can get away with it now, but it's a very different world and suggestive, I think, of significant concerns. It's not that that's changed any. We would always be concerned if that A student's starting to produce C's and if that B student is starting to fail. The difference now is just that there's so many more of those situations occurring that I think it's harder to keep track of at the school level.
We have a couple of questions. I'm gonna comment on one, and Dr. Alex, I'd love to hear what you have to say. The wait list for school refusal programs in the area is very long. What can families, schools do while they wait? So I'll give one thing that we're doing, and then I want to hear what kind of you have to say about this topic. This is something that you all that work in schools can do. That's why I'm sharing it. But I don't know if anyone is on here for even District 203 and some different districts. One of the things I do is when they identify families that have school avoidance or school anxiety or school refusal concerns, we talk about the student, we bring the student up, and then I or someone meets with the parents to do parent sessions to suggest ways to help. Some school districts are doing parenting groups that are targeted towards kids that have missed school for school anxiety, school avoidance, school refusal, parent training groups. And if anyone is interested, I could kind of share some resources on that. But there's it mirrors what, and I think many of you know, I helped start the school refusal program in Amita. So it mirrors what we do in the school refusal programs. The school refusal programs are all very similar, kind of where you go in terms of how they handle school refusal. It's a very common treatment. And so a big part of the treatment in the facilities is that parent component and the parent training. It's not always easy, and it's not easy at the program, but if you can start working with parents on some of that, some skills and some things to do and not do, one of the things I had referenced earlier is, one thing I've run across is many parents will say, we feel so sorry for them. They're so sick. They have medical issues. They have anxiety. They can't handle school. And so part of it is even educating the parents on kids with mental health issues and emotional issues do better with structure. And so if we can start by implementing some structure and consistency in the home with gradual exposure back to school, again, obviously we want them in a program, but if it's not realistic, there are things you can do. If you have that resource, I think it was Buffalo Grove High School in the beginning of the year, we did a couple parent groups just for parents that had kids with school refusal issues. And the parents said it was really helpful just to have some suggestions because they're so nervous about their kids' mental health that setting expectations becomes really, really overwhelming for them. And so when they start to learn that it's okay to set expectations, in fact, it helps kids feel safe as opposed to pushes them, which I hear a lot, it kind of starts to shift the mindset. And sometimes there's other things that you can kind of do that can help relatively easy, and sometimes there's not. So some of these school refusal cases will end up going to inpatient, unfortunately, because what happens is you have to almost, and Dr. Alex, you might not agree with this, and I'm not going to use the right wording here, but it's almost like the parents sometimes will tell me they feel like they've lost control in the house. And so in order to get control back and start to set boundaries, the kids really ramp up. And sometimes that means parents coming in and even getting them assessed for inpatient.
No, and I don't disagree with that. I think there's certainly instances in which, it's more than just a school refusal, and that is kind of tipped off, issues with substance use, issues with conduct, issues with mood that are being displayed through irritability, and it is not super common to have like school refusal in the absence of anything other than social anxiety. I mean, there's usually more to the story than just social anxiety that goes into any case where the school refusal is bad enough that you need that type of intervention for it. I've certainly admitted patients where school refusal has been a principal reason for why they've been at the hospital. And going back to that, like you said, I mean, if kids if children are so dysregulated, if teenagers are so dysregulated that people are fearful for their safety, that's why we have emergency, medical support. Now, is it better that it's police, or would it be better if it was a social worker team going out there? Right. I mean, that's another debate to have entirely. But I mean, honestly, the police do a decent job of this stuff when it comes to kids. I think they do a better job than that when it comes to adults. That there's this obvious thing I think that the police feel when they're going to go take care of a teenager that engenders them to the situation and has kind of this automatic empathy, at least in most cases, for the kids who aren't like spitting and attacking them. And so usually it goes well. And honestly, there's nothing wrong with that. That's why we have those services in place. That's why we all pay taxes and why we have those things. So I certainly wouldn't hesitate if somebody felt like that's something that they needed to do. I don't think it's a problem at all. From the what you do when you don't have access to a program standpoint, just keeping in mind that any school is better than no school. And so catching things when things are early, using access to the school therapists and counselors, and having a safe place for kids to go when they're feeling overwhelmed. Much better to be in a counselor's office, honestly, for the entire day than not be in school at all. And certainly much better to be in school for a couple periods, go to the counselor's office for a bit, go back to a period, go to the counselor's office a bit. That whole pattern, even if it's seemingly disruptive and difficult for maybe folks at school or for the student, are infinitely better than not going to school at all. Much easier to get back into things and avoid getting out of things when you're physically getting that exposure every day to the school environment. So anything we can do to prevent that, kind of end stage school avoidance where we're just not going at all will make a big difference.
Yeah, 100%. The only thing I would add to that is where I've gotten caught is whatever the plan is, just keep it consistent and have a plan. You don't want to end up with, okay, if you feel anxious, come to the office. If you feel this, come, because I find that then it causes more stress and anxiety for the kids. Many of these kids do better when there's a plan. You'll come here, you'll do this. And at first they're going to resist, avoid asking them how they feel about the plan. You don't want to kind of, because, and a lot of what we do too, and this is something, and everyone's strapped for time, but one thing we used to do, and Kathy's on here too, and Kathy works with a lot of school avoidant families. But we would talk about, okay, what happens the night before, what happens the morning of, don't do a lot of talking. I even have a script that, we've written out like what to say to kids in the morning and Fridays. If you're in a school, have Friday afternoon, you can even call the families and say, we know Mondays are difficult. Let's meet Monday morning and have like a 5-minute checkpoint. You could have all the families in there, whatever you want to do, depending on the age. But these kids are highly predictable. We know that they struggle without structure and consistency. So anything you can do to bring some structure, and sometimes it's gonna take a while. We have a girl we talked to recently, and she hasn't left her room in a month and a half. I can't get her in a program. So we're starting with, she's going to eat meals in the main living area. Then she's going to kind of come out, we're even starting there because that's where family feels comfortable. But I think we have to, I love how you said, Dr. Alex, we have to be realistic that we're up against a challenge, and sometimes we can only do what we can do.
Well, and the one thing that has been good about the pandemic is in the past, to that exact patient you're talking about, they would never be able to access services. But that's not the case anymore. You can see a psychiatrist remotely, you can see a therapist remotely, you can even do a PHP or IOP, remotely if you need something as a runway into doing this in person. Now, that's obviously not going to be the terminal end of treatment, but it's certainly something that can be done at the start of things. And if somebody really has developed, say, agoraphobia, like potentially in the case of this kid, there are medications that make a big difference in that, and certainly talking to a professional is the definitive treatment, of course, for that. And you can get some of that process going even for kids who aren't leaving the house, aren't leaving their room, which is a huge advantage compared to a couple of years ago.
Yeah. And one of the questions too, which I've run into too, is finding resources for families on public aid or don't have insurance. We've had a hard time finding psychiatrists. That's why I was like so impressed when you were doing the intakes. Now I'm just going to send all my patients to you for an intake. No, I'm just kidding. But you were so great with them. And I'm like, these families never would have had access to a psychiatrist, and so I thought that was amazing. What are Jody's asking, what are your thoughts on difficulties with getting parents to follow up on supports needed for a student expressing suicidal ideation when parents also struggle with similar things and aren't taking the issues that seriously?
Yeah, so it's tough, and obviously everybody's going to have a different, approach to that. It really depends on your intuition and understanding of how bad things are. If you have serious concerns about the child, of course, DCFS can be involved. If parents are not taking these things seriously, obviously you have an ability to you can call the police and do wellness checks if you're getting a very credible threat for something that's going on. It is very tough without parent buy-in, but at least in the child and adolescent age ranges, we have some things that we can do about it. If you turn 18 and want to, throw your life away, literally, there's not a lot many people can do to stop you. But in the adolescent age range, we certainly will have cases where we will take protective custody over kids that, parents are refusing to have hospitalized or admitted. I've done it many, many times, as of virtually all my colleagues who are in this space. We're not here to be paternalistic, but we're also not here to let some kid who's been stockpiling ammunition, sit at home. To give you an example of a case I may or may not have had. So, it's an important topic, and making sure that, when you're at the front lines, like if you are in like education or things like that, that any kind of contact that you can get with licensed mental health professionals is going to help, because the additional people on there are going to be people that can help you with those things if it does end up going down a coercive pathway. And obviously the real goal is that the more people you have involved, the more external voices a parent is hearing, it can break through and kind of make a difference. Sometimes it's because of what the parents are dealing with, and sometimes it's, I think, more just because of denial. It's very hard for a lot of parents to wrap their heads around the fact that their kids are in such a bad way. It's very easy to blame oneself for that and have a lot of protection up and trying to not admit that that's really what's going on. It's not every parent that's like that, but it's not an uncommon experience. Nobody wants to think that they messed up their kid or did something to cause their kid to have significant mental health issues. And so, helping work through that, helping parents understand, how tough of a time this has been for everybody, both for adults through the pandemic and for teenagers. And again, even independent of the pandemic, this has just been a completely brutal last 9 years to be raising an adolescent. It's a super hard job to be a parent in light of all this, and very hard to keep up with all the technology and all the changes that are happening for adolescents. And so, helping parents just get some empathy and understand this is a really tough spot that you're in. I get that, but really need to get help and trying to get them there.
Yeah, I think that that's an excellent point. And I think that's the one thing that's helped me, is I know a lot of times parents will say they're too fragile to handle us, doing anything, or they have medical issues, and when we talk about, these kids do better with structure and support, parents are just so scared to rock the boat, right? Because if they rock the boat, it could get worse. And I find in particular, if there's families that have had other family members that have had mental health issues or possibly completed suicides or things like that, they're even more scared to take them for help, because I think they think if they take them to help, it's going to get worse before it's going to get better, and they can't imagine it getting worse. And so sometimes with parents, we talk about it might get worse, and how can you manage that? Because typically when we take kids even to a partial program, I don't know if you all have had this experience, but Kathy and I used to, the kids would be worse the first couple of days. They would really ramp up their behavior. They would say, I hate it, it's terrible. And the parents would feel really guilty for dropping them off at a place like this. So we used to do a great job we would meet with the parents before the child started the program and say, your child's going to get worse the first 3 days. This is the kinds of things your child might say to you. Your child might really get upset. And we would write down for parents what to say in response to each of those things and what to do, so that the parents' anxiety would be, they'd feel prepared with their piece of paper. And it sounds silly, but sometimes, letting parents know that just because their child's struggling doesn't mean that they're not going to be okay. It just means they're struggling. And I think we have to help them sometimes, like you said, Dr. Alex, put it in perspective. We have a bunch of questions. Are you okay if I ask you the questions from the chat?
Yeah, please do.
Okay, I do have to put my glasses on just because. Some of the parenting issues were there all along. As you said, COVID isolation exacerbated them. Parents I work with seem to fear making their children angry 100%. As a result, children are not developing frustration tolerance and strongly act in a way to get their way. And Carol noted that.
Yeah, absolutely a concern if you're letting the child run the roost, or the teenager run the roost. So I think probably the rate that we see that is a bit higher now, but it's not a new concern. There have been bully teenagers, including to their parents, since as long as there's probably been modern society. And that's a really important area to touch on. I think almost everybody in the pediatric mental health space has had concerns about this specific patient population forever. I hear it from psychologists, from social workers, from therapists, from child psychiatrists. Yeah, absolutely, those family dynamics exist, and they're a huge problem. So figuring out a way to invert that and get that back, obviously the sooner you do it, the easier it is, and the longer it's been going on, the harder it will be to address. But that is an area you just can't let it get away and can't get it to that point. And if you do, you got to get it back under control. There's just no other ways about it, nothing else that can be done. Nothing will work if your child is calling the shots and has you in fear. That is priority number one, to change that before anything else is going to get better.
And I think I don't know if you all in schools would say this, a lot of schools are telling me, in which I kind of think that schools haven't necessarily adjusted the expectations for the academic demands, even though all of this is going on. They're still like expected to kind of meet the academic demands and meet the measures and meet this. And it would be interesting if we could kind of put more of an emphasis on that emotional health, much like, you have PE class. And I think you had mentioned that at one point, it would be much, if we could kind of put the emotional health just like the physical health.
Yeah, absolutely. I mean, that's a much longer discussion on revamping school curriculum that is seemingly impossible. I feel like there's very few things that are more glacially changing than school curriculum and how that's gone. It's very funny to talk to high schoolers because I talk to them about their classes. It's been 20 years since I've taken these classes. They're often taught in the same year of high school in the same manner as when I took it. The same classes are challenging versus not challenging. It's amazing to me how little of that has changed in 20 years. I thought I would be irrelevant, but somehow I still very easily able to empathize and understand where kids are at with things. But yeah, there's been some amazing pilot projects that have been done across some in this area and some across the country, teaching kids mindfulness techniques, teaching kids frustration tolerance techniques, work on self-identity and self-image, which is of course at the crux of what being a teenager is. And actually all those works have had great successes. There's been works on substance use prevention that are very effective. It's not DARE, in case anybody's wondering, but there are some very great programs that have been done that are very evidence-based and make a lot of difference. And so a lot of these population, level mental health basic 101 things have just not been part of education. And I'm really pleased to hear so many people from so many different spheres, not just practitioners and clinicians saying, let's do something about this. Let's try and change this. Let's make this part of the curriculum.
Well, and even advisory. I mean, back advisory and homeroom used to be like key, and you would do social emotional, you would work on relationships and just conversation. It was just a time to just relax. And I know it used to be like a 40-minute thing when I was in high school. And I think now some schools have it, but it's like 5 minutes, and then you try to fit all this stuff in 5 minutes. And, I think the silver lining of the pandemic is I think we are going to, and you've said it too, start to prioritize some mental health more, because I think, we do keep seeing more and more programs for mental health popping up, but I think at some point we have to be careful. We don't want that to always be the go-to either, as you said, like kids in programs. We need to kind of help them to function. In fact, I have some kids that, I don't even, I don't want to say I don't let go back to program, but we, again, try to pivot a little bit, because I think some kids do get very comfortable when they start going to some of the programs, and that can be a challenge too. A couple other questions. I am seeing a huge increase in students being diagnosed with anxiety and depression, and more students having suicidal ideation.
Yeah, so that was the case again prior to COVID, that the rates of SI were increasing dramatically. To give you some semblance, so the last time they had the American Academy of Adolescent Psychiatry in person is now a full 2 years ago. But at that, before, or I guess it's actually 2.5 years, my gosh, ago. At that time, before COVID, we were seeing like 9 to 10% year-over-year increases in the rates of suicidal ideation. In the adolescent population, that was going on for like, say, 6-7 years. So you think about inflation now and what inflation looks like at maybe a 7% rate, and how intensely life-changing that will be for our economy. You imagine, a rate 50% higher than that year over year, 6-7 years going on strong. 2013, I think, if memory serves, is when the spike was. And that's exactly the same year in which over 50% of adolescents had cell phones in their pocket. So the work is not like a definitive, we know 100% X is causing Y, but most people, most suicidologists and most people in the pediatric mental health space are, pretty sure that this is a big part of the drive of what's going on. So absolutely, that's a big concern. I don't know that I can't tell from your point if your question is this being overdiagnosed or is this increasing in incidence? I think most of it is increasing in incidence. We do not have like somehow this dramatically increased workforce. It's not like all of a sudden there's tons of people in the adolescent mental health space who are like, hey, we need to make these diagnoses to keep our schedules full. That is not the case at all for the field. We are dramatically behind in the number of people to provide the services that are actually needed. And so my suspicion is if you're seeing a lot more of that is because there is a lot more of that. And again, this is probably, I tell a lot of my patients and families, this is probably the single hardest time in recorded modern history, at least since the Industrial Revolution, to be an adolescent. The numbers were never as bad as they were over the last 7 years preceding COVID, and now we're 2 years into COVID. So that makes like 9 years of probably, essentially a decade of being the toughest decade ever. That we know of from a data-driven standpoint to be an adolescent. So this is, again, a very, very hard time for many, many people, many adults, many educators, but really the people that are seeing some of the biggest brunt of this are adolescents.
Well, I think too, one of the things I think about, and this has come up in a lot of the discussions I've had recently with families, is for kids to identify there's a lot of different ways to be successful. And I find that a lot of kids are continually saying, I don't feel successful, I feel like a failure. And I think for us to start to recognize that, a lot of these kids have to learn, and we've talked about this, Alex, it's okay to not be okay sometimes. And, I think we put pressure with influencers that you're supposed to be happy. And one high schooler said during a presentation I did with her that, we're being brought up to think that every morning we're supposed to, do a facial that takes 5 steps, and we're supposed to like do all these things to be beautiful, and it's stressing us out. And, you don't think about it, but it's like, these kids are under this impression that they have to look good, they have to be successful, they have to be smart. And then you start to feel like a failure. And that's when you start to like, what's the point? And so I think the best thing we can do is, even from an early age, start to let these kids kind of figure out who they are and how they want to express themselves.
Yeah, the big concern I get is that, so I see some of that for sure, and that's very present in the eating disorder population, the influence of Instagram, maybe TikTok, on generating some of those issues. I actually just yesterday interviewed somebody when they were in 4th grade. They were 5 feet tall and 95 pounds and just felt irrepressibly overweight, with a BMI of like 20-21 by the time they were 10. Admittedly, they did live in Miami at the time, but that's kind of the social media world and what people are seeing. I think the other big thing that I see from a lot of younger kids is they have a much bigger awareness of the global structure of the world, the understanding of what climate change is doing, what income inequality and kind of end stage capitalism has looked like is just completely different than when I was a kid. I was 16 years old. Everybody thought if you worked hard and went to college and got a job, you'd be able to have your own house and not live in your parents' basement, and you would be fine. It didn't matter if you got a degree in marine biology or went to become a carpenter or were going to drive a truck. You were going to be able to support a family and be fine. And that's obviously not the case for what teenagers understand to be the world these days. And so I see a much, much, greater number of kids where the generalized anxiety is about like the existential future of the world on one hand, but also their future of their ability to provide for themselves, have the kind of life that their parents had, and be able to do the things that they, have kind of told from an early age that they should be doing, and aka the American dream. And there's just so many kids where this is a significant concern, particularly kids who are doing well and still have, a huge, what it feels like to them at least is a huge albatross around them, even for kids who are, 3.8 students at very, prestigious high schools. So there are definitely, concerns to every generation. I'm sure other people grew up and had to do bomb drills and worry about atomic warfare, and it's not as though no teenagers have ever had any difficulties, but this current cohort are certainly facing down some pretty big stressors, and I think their awareness of it is just much, much higher than it has been in other generations because of the dissemination of information on the social media platforms and just kind of how news is accessed. I think it's not the same as it has been in previous generations, that there's really a fundamental difference in understanding of the problems of the world for teenagers that we're seeing with people like Greta Thunberg and things like that teenagers really do get it. But getting it is not always a good thing. Getting it is something that's really big and scary.
Mm-hmm. Mm-hmm. Also encouraging parents to understand and prepare for how to handle their own anxiety. I think that's a good point, Kathleen. Frustration, particularly in the mornings, helping parents to understand that sometimes it's about their own emotional stuff and reminding them to manage some of their anxiety.
Yeah, that's a great point. So the research is very clear, both on a individual level for specific patients. Treating the parent for anxiety is just as effective as treating the child and adolescent. So that's a wild thing. Treating a parent for depression also can be helpful, but there are very few conditions in which you can treat a parent and have the child have the same amount of improvement. And anxiety is easily the realm of anxiety disorders are easily the conditions in which that's the case. But interestingly enough, it's also true at the population level. So by treating, groups of parents for their own anxiety and getting them help, even that don't have clinically identified anxiety, that provides a population benefit to groups of kids. So it's a very important point when it comes to the anxiety disorders about the role the family system and the parents play in them.
100%. And that's why if you have parents that you refer the kids to therapy and the parents come back and say they refused, I always encourage the parents to still go. And there's some cases where I'll have the parents go to therapy. And I'll say it doesn't matter if the child goes or not. This is really for you both to start to kind of set a healthier atmosphere in the home, because therapy with kids is great, but it really has to coincide with, changing some things going on at home too, I believe. And I love this one too, Stacy. Important to remind parents that hospitalization is stabilization. It's not healing. Healing takes time. And that is really true. Hospitalization, parents always come back. And I think, again, setting up the realistic expectations that you're not going to get all this therapy and uncover like your inner self and inpatient. A lot of times it is more about, right, Dr. Alex, stabilization.
Yeah, absolutely. I mean, part of that is because of how this has changed over time, right? So 20 years ago, when you went to an inpatient unit, you'd be there for a month and it functioned as what the equivalent of a residential treatment is now, right? And insurance companies are not super keen, as it turns out, to pay $3,000 a day for 30 days when they can help it. And so obviously there's been huge pressures in the field, but also a good thing, I think, in some ways to not have people be, locked up and be in these situations for as long a periods of time as they have been historically. So, it was true in the past that inpatient units were actually used to treat disorders. Nowadays, they are not used to treat anything. They're almost just entirely built around stabilization. I mean, it's not nothing that's treated if you're acutely manic. Of course, we would expect that to be treated on a unit if you're psychotic, recovering from like a substance-induced psychosis. Those are things that are, rapidly addressable in the hospitalization setting. But by and large, the absolute majority of patients, it is absolutely just about stabilization, setting up a good plan, having a family session or two to make sure that people are on the same page, and then really what that step down is going to be. And that's the reason why you see this rapid expansion of partial hospital and intensive outpatient programs, is because you're trying to make up for the space of where can you go when once a week therapy is not cutting it. There's a lot of people in a lot of places where once a week therapy is just not enough, or even twice a week therapy is just not going to cut it and is not enough. And we certainly rapidly identified that in the mental health space, and that is partially because of the shortening of hospitalizations, and also partially because it would be really nice to avoid needing hospitalizations and not just jump from once a week therapy to inpatient. And so that is absolutely why you see so many PHPs and IOPs these days.
Have you noticed any kind of increase in psychosis with children and adolescents? And is there any, if you have, is there any reason why? Or that was another question.
I don't think so. I did not find any data on that when I was giving my presentation last month. It's a harder area to access, and there's not a huge amount of psychosis in this population anyway. Most of the time when you do see it, it's associated with either mania or very severe depression. But substance-induced psychosis is definitely a thing, and you see a fair amount of that in adolescents. And interestingly enough, much of adolescent substance use went down during COVID, in stark contrast to adults, where it went up significantly. Part of that is because how kids access their substances is very different than how adults do, and they really are driven through the peer networks. And we obviously shut down a lot of peer networks when COVID was out and about. And so it's interesting in that, this is one of the few areas that's we actually had improvement in some things. Somewhat terrifying that all these things are getting as bad as they are, and it's not driven by substances. So it means that there's another thing that's causing all these problems, which is not the positive side of the coin. But the one positive thing is that there's been reductions in most areas of substance abuse, even if not traumatic. They certainly haven't gone up. And so you have less, driven psychosis from that. But I have not seen great data to say if it's moved one way or the other. I suspect it's probably pretty close to its baseline.
What, and this is the final question we have in the chat, and then we'll start to talk about the CUs and start to close things up. What can schools do to support students with eating disorders?
Yeah, that's a great question. So it certainly depends on the patient and where they are in their stage of recovery. There are certainly some folks who have a really hard time eating in front of others. And so having a space for them to eat that's not heavily observed could be beneficial. There are other kids who are going to be in kind of programs where they really need support during their meals as well. And so if there's an ability for that to be provided, by a therapist or counselor at school during the mealtime, that can make a huge difference. Supportive meals and being able to continue the progress that families are working on with breakfast and dinner and snacks can be extremely beneficial. So, again, it just depends on sort of where kids are at. The other thing is just helping people identify that it's an issue and come in. Eating disorders are a little unique compared to most of the other disorders in adolescence, in that they really tend to impact insight. And so the understanding that something is wrong, it's not uncommon for me to have kids just be melting down and saying, there's no way that they're getting treatment. There's no way that they would ever gain weight. That this is like the worst thing imaginable. And that's the corruption of the brain that happens with eating disorders, that you lose this understanding of what's actually happening inside your body, what's actually healthy, and how you actually appear and look. Actually, there was a patient yesterday, and their potassium was low because of their eating disorder, which is very scary. I mean, you can die from cardiac arrest from that. And they had just a complete and utter meltdown when trying to discuss treatment. There's no way that they would engage in that, is what they're saying. But getting that patient in front of me and getting the ball rolling is going to be life-changing for them, and they'll get help. And mom was very on board, and things will get better. Eating disorders have actually very high response rates to treatment. It just needs to be an intense treatment, and a treatment that started as soon as possible. So other than the help during recovery step, which can make a huge difference, the other big thing is just helping to identify. And in fact, I've had multiple patients who've come in and said, my therapist at school thinks I might have an eating disorder. This person at school was saying something. Obviously, I'm sure they said it in a healthy and appropriate manner, but that can be a life-changing thing. You guys are on the front lines there and seeing folks before anybody does in the clinical services, and being able to just help identify if kids losing a lot of weight in a hurry. The suspicion for an eating disorder should be very high.
The last question I guess I would have, and there's not an answer to this, but we are always trying to figure out how to find psychiatrists and how to find psychiatrists that have openings, and how to try to find psychiatrists that kind of take the insurance.
Yeah.
Is there like a place we can go? I mean, this is literally every day. We're like, even in our own Center for Emotional Wellness, there's only 22 of us, and we're like, where do we go? It's continuous. Is there any suggestions?
No. So the reason that there's not is because everybody's got about as much work as they want, and they really fill, nearly instantly. Certainly the Medicaid insurances are going to be by far the toughest, and the academic centers are by far the best for those. you get great quality care, and they all take Medicaid. The problem is, virtually impossible to get into. So, the best way to go about it, if you have somebody on Medicaid, is to get embedded into a healthcare system that is, in an academic center. So getting to see a pediatrician, a primary care doctor. I know at UIC, they won't even take referrals unless you're in the network already. I think Northwestern is similar. And so getting somebody into, UC, Northwestern, UIC, to have them in their primary care network will give them a chance of being able to see somebody. Very unlikely to have a chance otherwise. There are very, very few people. I mean, we would get paid less, or we do get paid less than most hairstylists, for a unit of time to take care of Medicaid patients. And so, as you can imagine, that's not a very common route. People have to really be in it for a very specific reason to be able to do that kind of work, just because of the way the reimbursement is set up. There's such a big discrepancy between Medicaid and Medicare in this country, as many of you know. And so it's very telling that we treat our children like second-class citizens and treat the older, much better at voting block of individuals, to a much, much higher standard. Most docs are thrilled to take Medicare patients and just don't see Medicaid patients. So this is just kind of where the state of healthcare is at. Even with private insurance, I mean, you can certainly call your insurance company to get a list of in-network docs. As many of you know, most of the time that's going to lead to a bunch of people who either don't have openings or who literally don't exist, who don't work there anymore. They don't keep those listings up to date. They have no incentive to, because they don't really want you to get care. Insurance companies have a very unusual setup where, because people change insurances so frequently, they would rather not spend $10 now, even if it would save them $1,000 10 years from now, because they don't think it's very likely that you will still be on their insurance at 10 years from now. There's just very perverse incentives for insurance companies from that. So there's not like a unified source for that. I will tell you, even for us, it is complicated sometimes getting people follow-ups with people that we know well. Because everybody is so full. We maintain, our own internal lists of referral sources, but they're treated, somehow like royalty or gold. It is just so incredibly difficult. So, being in a healthcare system that has child and adolescent psychiatrists is a great start. So, like North Shore, for example, does a lot of that up here, although they don't have very many child and adolescent psychiatrists. Their program has, difficulties supplying that as well. But being in a healthcare system is oftentimes the easier way to go. And then, getting individual referrals to individual docs through word of mouth. It ends up being the case, because almost everybody's full, and almost everybody will only take somebody if they have a reason to know you and have something specific there. And believe it or not, that's even better than it is in most parts of the country, where you just have no chance of getting in. At least in Chicagoland area, you could try real hard, expect a significant wait, but actually get to see somebody at some point in time. Many parts of the country, it's not even in the realm of possibility.
This truly was awesome, Dr. Alex. You did a phenomenal job.
Thanks again for having me. Appreciate it.